be speaking on pharmacological treatments for tobacco. This is my disclosure information. Our learning objectives are to review the risks, role, and benefits of FDA-approved medications for treating tobacco use disorder, including indications and contraindications, special precautions, and warnings. These are the DSM-5 criteria for tobacco use disorder. Note that the nomenclature has changed compared to DSM-4. It's no longer called nicotine dependence. The criteria are essentially unchanged from prior editions. One of the only changes is the addition of the new criteria for craving. One of the unique aspects of this drug syndrome is that most people that use this drug in fact meet criteria for the use disorder, which is different than patterns of other drug use. For example, alcohol, where many people use alcohol and few actually meet criteria for an alcohol use disorder. Tobacco has a withdrawal syndrome that's associated with abrupt cessation or reduction in tobacco use can precipitate symptoms of withdrawal that can include sad or depressed mood, insomnia, irritability, anxiety, trouble concentrating, restlessness, and feeling hungry. These symptoms can emerge within hours of last tobacco use and are likely seen throughout the course of the day, but missed because of the nonspecific nature of the symptoms of tobacco withdrawal. It's hard for smokers to quit without treatment. Many will report wanting to quit, but few will succeed without treatment. In fact, the numbers for quitting cold turkey suggest that less than 5% will ultimately succeed on a quit attempt if they quit on their own without treatment, suggesting that 95 out of 100 go back to smoking. We see that the success rates with treatment are much better than this. Pharmacological treatment is considered a first-line treatment for tobacco use disorder. The rationale for using medication, the main one is to reduce or eliminate the symptoms of tobacco withdrawal, but the medications have other effects as well. They block the reinforcing effects of nicotine. This means that if someone's using one of these medications and they smoke a cigarette, they're less likely to enjoy that cigarette. The medicines also lessen or delay the weight gain associated with quitting smoking and double the chances that someone will be successful in making a quit attempt. Thus, they are a proven and cost-effective component of treatment. There are 7 medication treatments which are FDA approved and are considered first-line treatments for tobacco. They include nicotine replacement therapy, which is often referred to as NRT. There are also 2 non-nicotine treatments, including bupropion. Bupropion goes by several names, including Zyban and Wellbutrin, and the last non-nicotine treatment is varenicline or Chantix. Keep in mind that even though we're talking about medications, that the best treatment plan for a tobacco user is always a combination of counseling plus medication, which gives people the greatest chances of success in quitting. There are 5 different types of nicotine replacement medications. These include the patch, gum, lozenge, inhaler, and nicotine nasal spray. The first 3, the patch, the gum, and the lozenge, may have the advantage in that they're all available over the counter without a doctor's prescription. But there may be cases where it's advantageous to actually write a prescription for these medications if the out-of-pocket cost is too high and if the state Medicaid program covers it, which is true in many states and could allow patients greater access to these medications at no cost. I'll make a few comments about nicotine replacement medications. Nicotine is not responsible for most of the diseases associated with smoking. So for example, cancer, pulmonary disease, and heart disease are not due to the effects of nicotine. They're from the effects of the other thousands of chemicals contained in cigarette smoke. Nicotine itself is not a carcinogen. That's why it's available as an over-the-counter treatment for tobacco addiction. The themes of using nicotine medication are to use nicotine in a high enough dose. The doses that are delivered to the patient from nicotine replacement medication are often lower than the doses that they might achieve from smoking. So it's important to use these in a high enough dose to be effective. In that way, when someone makes the decision to use nicotine replacement medication, you would recommend that they use it in a scheduled way. For example, a dose every 1 to 2 hours, rather than just waiting PRN for craving. It's important to use these medicines for a long enough time period. There's a lot of safety information suggesting that even the long-term use of nicotine medication is fairly safe. Nicotine medications can be combined with bupropion safely, and they can be combined with each other. There's almost no contraindication to the use of nicotine medication. If a person is smoking cigarettes, they would be a candidate for nicotine replacement medication. Nicotine has no drug-drug interactions, and again is safe enough to be considered as an over-the-counter medication. Unfortunately, though, many smokers remain misinformed about the safety and efficacy of nicotine medications. Again, that nicotine does not cause cancer and is not a significant risk factor for cardiovascular events. The risk-benefit ratio suggests that every tobacco user would be better off using nicotine replacement medication in lieu of ongoing use of tobacco. I'll make a few comments about the different nicotine products. The nicotine patch is extremely easy to use and is simple and therefore is associated with good compliance. The nicotine delivered from the patch has a slow delivery to the bloodstream, but provides continuous nicotine delivery over a 24-hour period. Remember, waking up in the morning to smoke a cigarette is one of the measures of level of nicotine dependence. So in fact, you wouldn't want people to wake up in the morning in tobacco withdrawal, and you would recommend that patients try to wear the nicotine patch throughout the night unless they're having a sleep disturbance from it. Nicotine patch can be done without a strict tapering schedule or timeline, and side effects to the nicotine patch tend to be mild, including a mild skin irritation and abnormal dreams and risk of insomnia. These three products, the nicotine gum, the nicotine lozenge, and the nicotine inhaler, I'll consider as a group because what they have in common is that these are oral forms of nicotine, where the nicotine is essentially absorbed into the bloodstream through the lining of the cheek, what's called the buccal mucosa. That's not a very efficient way to deliver nicotine to the body, so another similarity of these three products is that they deliver a fairly low level of nicotine replacement from a single use. Therefore, they often have to be dosed frequently, every 1 to 2 hours, to be effective. Absorption of nicotine through the lining of the mouth is slow, and acidic foods and beverages will further interfere with the nicotine absorption. So you have to provide psychoeducation with these products that people should not use them with coffee, soda. Most beverages are acidic and will interfere with the absorption of nicotine. Side effects tend to be mild and can include irritation to the mouth, but usually these are well tolerated. A person can get stomach upset if they swallow too much nicotine from the gum preparation. And again, instructions are to chew the gum slowly and to try and hold the gum in your cheek, a technique that's referred to as bite and PARC to allow the nicotine time to be absorbed. The nicotine inhaler is a prescription product, whereas the gum and lozenge are available over the counter, but in many ways these products work in the same way. The inhaler sounds like the product would deliver nicotine to the lung, but in fact it's really more of an oral puffer and delivers nicotine to the mouth. Out of all of the products, the nicotine nasal spray has the potential to provide the greatest dose of nicotine delivery in a day because nicotine is rapidly delivered through the nasal mucosa. However, in practice, it also has the highest discontinuation rate and is associated with the most side effects, including nasal irritation, watering eyes, and coughing. So in practice, it is rarely used. The FDA in 2013 provided important labeling updates regarding the use of nicotine replacement medications. There are no significant safety concerns associated with using more than one nicotine product at the same time. There are no significant safety concerns associated with using nicotine even at the same time as a cigarette, and use longer than 12 weeks is considered safe. In fact, this information is also included on the packaging instructions, so you might notice new directions for use on over-the-counter nicotine replacement products that say, keep using the medicine even if you slip and have a cigarette, and use beyond 12 weeks is okay if needed to quit. There's often a lot of concern about what will happen when patients smoke while using nicotine replacement medications. However, the evidence is that this is a relatively safe practice and can even be considered as a form of harm reduction, because if patients, for example, are wearing the patch on a daily basis, they will tend to smoke less than they did at baseline. One of the reasons is that they will get less enjoyment from cigarettes as a result of using concurrent nicotine replacement medication. And we used to discontinue nicotine medication in the context of a relapse, removing patches when we caught people smoking, but perhaps that's not the best way to approach treatment, where we withdraw treatment. It could be seen as a kind of punishment for relapsing from the patient's perspective. Some of the evidence about the safety of nicotine medication, even in the context of continued smoking, comes with decades of use with these products, and also studies which have been conducted in the UK, where they're doing innovative approaches to reach low-motivated smokers. This approach is referred to as cut down to quit, where smokers are being provided with nicotine replacement products, even if they do not say that they want to try to stop smoking, where they're being encouraged to use the products even while they smoke with the intent to help them cut down. Some of the published results of these studies are available. This is one analysis that included several of these trials of almost 3,000 smokers who essentially smoked while using nicotine replacement products for a prolonged period of 6 to 18 months. These studies showed that almost 7% of smokers receiving nicotine replacement actually quit smoking, even though at baseline they reported no desire to quit, and that this was significantly more than those who had received a placebo. But perhaps more importantly, from a safety perspective, there was a lot of evidence that this practice was safe and that there was no statistically significant differences in adverse events and discontinuation because of adverse events, with the exception of nausea. So in fact, nausea is one of the main symptoms that can occur with smoking while using nicotine replacement products, but in general, these are safe and well tolerated. The next treatment I'll discuss is bupropion. Bupropion is the same medication that's used in mental health settings as an effective antidepressant treatment. The dose that's used for smoking cessation is essentially the same or similar dose of 150 to 300 milligrams per day. Bupropion is a non-sedating, activating antidepressant with effects on norepinephrine and dopamine systems. It's typically started 2 weeks before the time that someone is going to try to quit. It has common side effects including headache and insomnia, and should never be used in people with a history of seizures or eating disorders. The mechanism by which bupropion is effective in helping people to quit smoking is not well understood, but there is some evidence that bupropion has activity at the nicotinic receptor as an antagonist. Overall efficacy with the use of bupropion is similar to nicotine replacement medication, and its effect is independent of its effect on depression. It was marketed at a dose of 300 milligrams, which was associated with the least amount of weight gain in quitting smoking. Bupropion has been associated with some serious adverse events, including severe risk for allergy, neurologic reaction, including seizures, and the possibility for neuropsychiatric side effects, including suicide attempts. The next medication is varenicline. Varenicline has a different mechanism of action than the other treatments. It's a selective alpha-4 beta-2 nicotinic receptor partial agonist. That means that varenicline is targeting the brain reward pathways that are involved in the biology of addiction. We know that there are nicotine receptors located in this part of the brain, specifically the ventral tegmental area. These receptors become activated when people smoke cigarettes. An activation of these receptors sets off a cascade of events, including the release of dopamine in the nucleus accumbens. This is how we understand the biology of addiction to nicotine and also to other substances. And this medication was developed based on understanding this neuroscience. Varenicline has a variety of ways in which it's effective. As a partial agonist, it partially stimulates the alpha-4 beta-2 receptor and causes the release of some dopamine in the nucleus accumbens. As a partial agonist, it causes a longer and slower release of dopamine, and overall less dopamine is released compared to a full agonist like nicotine. So varenicline itself is not addicting. By binding the receptor, varenicline prevents the nicotine receptor from going into withdrawal. And varenicline essentially also works as an antagonist because when it's bound to the receptor, it blocks nicotine's ability to activate the alpha-4 beta-2 receptor. So it has this variety of ways that it works to treat tobacco addiction. Varenicline also has no drug-drug interactions. The reason it has no drug interactions is because it's excreted, mostly unchanged by the kidney, in the urine. This is a table showing the comparative effectiveness of the first-line medication treatments. If we look at the patch, the gum, the inhaler, the nasal spray, and bupropion, we can see that the odds ratio for all of these treatments is approximately 2. This means that these medications are effective and double the chances of success in making a quit attempt compared to a placebo treatment. Varenicline is associated with a higher odds ratio of 3, suggesting it's more effective than these other treatments when used as a monotherapy. The most common side effects of varenicline noted from clinical trials included nausea, insomnia, abnormal dreams, constipation, flatulence, and vomiting. It's recommended that varenicline be dosed twice a day with food, which reduces nausea. Varenicline is associated with labeling updates. People that have used varenicline have noted that they had serious neuropsychiatric symptoms, including changes in behavior, agitation, depressed mood, suicidal thoughts, or behavior. This comes from case report data, not from clinical trial data, and at this point, Causality has not been established, so it's still not clear that varenicline actually causes these side effects. The most recent meta-analysis looking at clinical trial data where varenicline was tested compared to a placebo treatment does not suggest that varenicline is associated with these significant neuropsychiatric side effects. So for example, this was a meta-analysis of 39 randomized controlled trials, including more than 10,000 participants. The study was not sponsored by the commercial sponsor Pfizer and included a range of industry and non-industry funded studies. This analysis, this large meta-analysis, suggested that varenicline is not associated with an increased risk of suicide, suicidal ideation, depression, irritability, or aggression, although varenicline has been associated with sleep disorders, insomnia, abnormal dreams. Interestingly, varenicline is associated with a reduced risk for anxiety. So the clinical trial data is not really consistent with the case report data, which is a bit of a question mark about varenicline, although typically we put more support behind clinical trials that include a placebo group. This is a published review in Current Cardiology Reports looking at the risk for cardiovascular side effects associated with each of the medication treatments for tobacco addiction. There's no increase in risk for serious cardiovascular events in those using nicotine replacement compared to smoking. Use of nicotine replacement can be used as quickly as 2 weeks after a heart attack, myocardial infarction, and can be used at the time of discharge from the hospital or ER for chest pain or angina. There's also no evidence of increased cardiovascular events associated with bupropion use or varenicline. These authors concluded that these medications overall have a very low risk of harm and that the benefits outweigh the risk of serious adverse events associated with tobacco, and that we should be using them more regularly in patients. There's increasingly use of combination therapies to help increase abstinence rates and success in quitting. Combinations of medications can decrease withdrawal and tend to be well tolerated. This is an analysis from the Public Health Service Clinical Practice Guideline for treating tobacco, which supports that 2 nicotine products used concurrently had a higher odds ratio than 1, so double the chances of success. Similarly, a combination of patch and bupropion can be more effective than using either alone. This is probably one of the better studies, doing a comparative analysis, head-to-head trial of the different pharmacotherapies. In this large study of 1,500 smokers, patients might have received or been randomized to receive nicotine lozenge or patch or bupropion. 2 groups received a combination. One of the combinations was nicotine patch plus lozenge, and the final group received bupropion plus lozenge. And this head-to-head trial that also included placebo groups. In fact, the treatment of nicotine patch plus lozenge was overall the most effective. It provided the greatest time to relapse back to smoking and the highest success in quitting 6 months after quit date. This combination was clearly superior to monotherapy with nicotine lozenge, patch, and bupropion. The bupropion combination literature has been mixed in terms of its overall effectiveness. In this trial, bupropion and lozenge did not appear to be significantly better than either treatment alone. There have now also been several clinical trials looking at varenicline in populations with mental disorders. This was a fairly large study of smokers with major depression who had stable illness but still some symptoms at baseline. Most of this sample were still taking antidepressant treatments. Varenicline was effective in this trial, More patients who received varenicline quit smoking compared to those who received placebo. And the safety information from this study was quite good. There was no evidence of worsening depression in this clinical trial associated with varenicline or placebo. There was no difference in rate of adverse events, including depressed mood, suicidal ideation in the varenicline group, showing these depression scores. In fact, the trend in the study was that depression and anxiety slightly improved. There's also a trial of varenicline in smokers with bipolar disorder, again looking at various safety outcomes and symptom measures. Varenicline was given in a standard dose with brief weekly counseling in smokers who were interested in trying to quit smoking. The safety information was quite good. There was no changes in bipolar symptoms and no differences between the two groups in terms of dropouts due to side effects. There was a higher rate of abnormal dreams in smokers that received varenicline, but no difference in rates of mood changes or suicidal ideation. And the efficacy of varenicline was quite good and superior to placebo in helping smokers with bipolar disorder to quit smoking. Finally, there's been studies looking at varenicline in smokers with schizophrenia where the results are quite similar. Varenicline is effective at helping patients to stop smoking and superior to placebo. And the safety information from this study was also quite good. There was no evidence of worsening of psychosis in patients who received varenicline. In fact, safety symptom scores remained fairly stable throughout the course of this study, as measured by the PANSS positive and negative symptom scale. Dr. Eden Evans did an interesting open-label trial where she gave patients with schizophrenia and bipolar disorder open-label varenicline. At the end of 12 weeks, she took those who were successful in quitting smoking and randomized them to either continue varenicline for a year or to be switched to a placebo group. And you can see that those who remained on varenicline had reduced rates of relapse. They did better. Although some did relapse, the rates are much lower compared to those who were switched to placebo, suggesting a role perhaps for maintenance treatment or extended treatment for relapse prevention. Briefly, I just want to mention that there are other medications that have data suggesting effectiveness, but that these are not FDA-approved treatments. This includes nortriptyline, clonidine, and cytosine, which is not available in the U.S. SSRIs and naltrexone, in contrast, have not been shown to be effective for treating tobacco use disorder. The last point I want to make is that there are important medication interactions which occur with tobacco smoke. Cigarette smoke gets into the body and induces one of the hepatic isoenzymes. Specifically, it's the 1A2 enzyme. This is a negative effect because this means that if you are a smoker and you take one of the medications that's impacted by 1A2, you have a faster than normal metabolism of these medications, which drives down the blood level of the medication. It makes it appear that the medication is not effective, and so smokers tend to be on higher doses of these medications. Just by chance, it turns out that the medications that are impacted by 1A2 are mostly psychiatric medications and include a range of commonly used antipsychotics and antidepressant treatments. The ones in red are the most clinically relevant in terms of having a great impact by this tobacco smoke interaction. Note here that caffeine is also on the list. Caffeine is also largely metabolized by 1A2. So it's not a coincidence that smokers also tend to be high utilizers of coffee and other caffeinated beverages. They're essentially drinking more to compensate for this rapid metabolism. The opposite can also occur in the context of quitting smoking, where people can be at risk for medication toxicity from these medications, where blood levels may rise rapidly in the context of quitting smoking. And out of all the medications on the list impacted by smoking, clozapine is the most potentially dangerous in terms of its potential for toxicity and seizure. So you might consider dose adjustment, or at least be vigilant about the potential for these changing drug levels in the context of stopping smoking. It may also be useful to help recommend to patients that they reduce caffeine intake in the context of stopping smoking so that they don't experience caffeine toxicity. And remember, this interaction does not come from nicotine. It comes essentially from the tars in tobacco smoke. Nicotine itself doesn't have any medication interactions and is metabolized at a different enzyme, cytochrome P450-2A6. Just to review briefly the potential for medication interactions from these different treatments. Nicotine, as we said, is metabolized by 2A6 and has no important clinically significant medication interactions. Varenicline is excreted mainly in the urine and also has largely no medication interactions. Bupropion, which is metabolized by 2B6 and is a 2D6 inhibitor, has the potential for several medication interactions, which are not included on the slide. So to conclude, these treatments increase the success rates in quitting smoking and should be used more in all smokers. Nicotine treatments are effective and well tolerated. Combinations improve outcomes, and varenicline has evidence of greater efficacy than prior monotherapy treatments. Thank you.